Welcome everyone. Thank you so much for taking time out of your day to join us for this first meeting of what we hope becomes a series of discussions and conversations for an injury and disability insurance data interest group. My name's Alex Colley. I'm a professor at the School of Public Health and Preventive Medicine at Monash University, and we'll tell you a little bit about us today. Before we begin, I just wanted to acknowledge the traditional owners of the land on which I'm joining you from, which are the Wurundjeri people of the Kulin Nation, and pay my respects to elders past, present and future, and also to my respects to the owners of the land from wherever you're joining us today, from around the country. We have people from all over Australia, which is lovely. So this is really an initiative of our research group at Monash, which came about through conversations between myself and Michael, who you'll hear from today, who's one of our very clever postdoctoral researchers, just to try to get people together who are interested in data in all its forms in our injury and disability insurance schemes in Australia. And what we hope to do is just provide a sort of informal, regular opportunity for people with that interest to get together, share knowledge, exchange ideas, learn from one another. We spend a lot of our time thinking about data, how it's captured, how it's used, how it's analysed, how it informs policy or practice or doesn't. And we know there's lots of people working in the sector similarly who spend a lot of their time thinking about it and using it. But we did notice that we don't really have, apart from periodic conferences and sort of large-scale events, any opportunity to get together and just discuss what we're doing and what we're learning. And that's really the point of this group. We thought it could be sort of a relatively low-cost way, just doing it online, now that we're all used to Zooming in and doing Teams and things, of getting together and connecting. And that's the point. So it's a bit of an experiment from our point of view. We've had a really, really strong response to the promotion that we put out sort of late last year. I think we had over 80 people register for this one. I'm not sure how many will show up. Some people may be choosing to eat lunch rather than come and join in the conversation. But I think over time, our aim is to sort of grow this and just create a bit of a community around use and application and capture of data. Ultimately, hopefully what we'd like to do, if you could just go back, Michael, we'd want to sort of promote better understanding of the use of data within our personal injury and disability insurance sector. And our sort of rough goal, and it's to be determined based on the appetite and people's willingness to present and get involved, we thought we'd try to meet every 2 months and have someone from the group presenting at each meeting. We're happy to convene it and organise the invitations and the Zoom meetings and those sorts of things. So we'll do all the legwork, but we would love to encourage people to come along and present your work and show the other members what you've got and have a conversation. To kick off this first one, we're going to present some of the work that we've been doing over the last few years, which Michael will lead. I should let you know before I go any further that the meeting's being recorded. We're going to make the session available online through our website. So if you miss anything along the way, you'll be able to come back and watch it, and you can share it with your colleagues as well. So please do that afterwards. We'll circulate a link to the video as we go. When you joined, you'll have noticed your mic's been turned off. I could ask you just to keep them turned off during the presentation. We're hoping to have plenty of time towards the end for a sort of Q&A and a discussion, and we'll sort of moderate that as we go. That's about it. We thought we'd start with a little poll to see who is joining us. So we've got one question for you, and we're going to try a Zoom poll, which is not something I've managed before, but Michael assures me he can do this through Zoom. So we'd like you to answer this one question, just so we can get a bit of a better sense of where people are from, and it'll give us an idea of your background. So hopefully you've polls come up on your screen. You can click a response and press submit. Yep. And we will hopefully be able to sort of report back on that towards the end of the session. Or if not, we'll report back on it afterwards. Yep. Okay, almost it from me. One more thing from me. Thanks, Michael, for shepherding me through this. Just a little bit about our research group. Some of you may know who we are and what we do. We've worked with a few people I noticed on the call as we were logging in. We're based at Monash University in Melbourne. Our team is called the Healthy Working Lives Research Group, and we do lots of different research, really looking at occupational health and occupational rehabilitation and return to work across 3 themes of prevention, recovery, and systems. We have multiple projects underway, funded by a variety of sources, such as the National Health and Medical Research Council and the Australian Research Council, and quite a lot of research that we do in partnership or collaboration with regulators and insurers and employers and community organisations around the country. And increasingly, we're moving into education as well. We're through a recent partnership with PEACE, the Personal Injury Education Foundation. And I guess really our sort of approach to this is that good work is good for health and good health is good for work. So we try to do research that enables that positive feedback loop between good health and good work. That's all the promotion you'll hear about us today. So that's it. With that, here's the agenda. So we're going to hear from Dr. Michael Di Donato, who's going to present some work that we have been working on for a number of years now. Some of you may have seen some of this in other forums. Michael's going to attempt to encapsulate years of work in 20 minutes, and then we'll have an opportunity for discussion and Q&A. When we get there, I'll try to moderate it and work people through the putting your hands up and asking questions. You can ask questions about Michael's presentation or about the group. And as we're going through, I just encourage you to think about whether you've got something you'd like to present at a future one of these sessions as well. So without further ado, I'll hand over to Michael, who's going to take us through his presentation. Thanks, Michael.
Thanks, Alex, and thanks everyone for being here for the first meeting of our interest group. It'll be great to hear from other people in the future and make some connections and discuss data. So today we'll talk a bit about our new database, the development and initial application of a harmonised multi-jurisdiction workers' compensation injury compensation database. So this presentation uses data supplied by WorkSafe Victoria, WorkCover Queensland, Return to Work SA, WorkCover WA, and Comcare. The views expressed in this presentation by myself are those of myself and the co-authors, not necessarily the views of those workers' comp regulators, and we thank them for providing data for this project. In the spirit of reconciliation, we also acknowledge the traditional custodians of the country throughout Australia and their connections to land, sea, and community. We pay our respect to their elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples today. So health services and workers' compensation. Every state and territory has a workers' compensation scheme. In 2020, 2021, there are about 140,000 claims with greater than a week of time loss, so a fairly substantial number there. Services to claimants is the second largest cost after wage replacement to workers' compensation claimants, about $2.4 billion per annum, as you can see here. Services to claimants in 2019-20, just under 2.4 billion. And that's up 24% since 2015, sorry, 22% since 2015-16. So quite a substantial proportion of the cost of workers' compensation. But there are things we know and things we don't know about health services for workers' comp. So we know a lot about the worker and their claim. A lot of the data are inherently logical, such as age or sex, where sex is binary. There's a lot of standards available for occupation, industry, injury as well. So coding standards for how something should be described. There's some census-derived metrics such as socioeconomic status or remoteness that we can attach to geographic data like postcode. And a lot of this claims data, all of the claims data, I should say rather, is compiled by Safe Work Australia annually for reporting and for research purposes. But data about healthcare services delivered to workers is a bit more of a challenge. So there's no real standards or accepted systems or indicators for healthcare services nationally. Some schemes use MBS codes, but most schemes cover services that are not included in the MBS, so they have to make their own items, which means one jurisdiction might make one item to describe something, and the other jurisdiction might make a different code to describe almost the same thing. And the data, what we could say is siloed into each jurisdiction. So there's no national data source for comparison or reporting on the prevalence, nature, timing, continuity, or quality of healthcare to disabled or incapacitated workers. So we built a new data source. The multi-jurisdiction database includes claims for low back pain, limb fracture, and non-specific limb conditions such as muscle, tendon strains and sprains, but for claims between July 2010 and June 2015, so 5 Australian financial years. And it includes claims and payment information from Victoria, Queensland, South Australia, WA, and Comcare. So low back pain was really the focus of this database. And why start with low back pain? Well, there's a lot of claims, over 56,000 claims for low back pain longer than 2 weeks between 2010 and 2015. There's clear evidence-based recommendations to measure best practice against. Diagnostic and treatment options recommended or recommended against in the evidence that are supported by strong recommendations and are also, and importantly, easy to detect in structured administrative data. That's the kind of data we were aiming to work with. And we can also make comparisons with relatively similar jurisdictions like Canada. So a bit of an example here of how that might be detected. So for example, diagnostic imaging is not really recommended for new cases of acute low back pain. But if we detect a high prevalence of MRI or X-ray or CT in some administrative data, that could be indicative of non-best practice. So it's relatively easy to detect that kind of thing in admin data. The database contains 4 linked data sets effectively. The claims data set, which is our typical information about claims, injury, demographic data. The services data set is brought together using a harmonized coding scheme that we developed ourselves. And at the moment includes services such as GP services, physical therapy services, psychological therapy services, diagnostic imaging. There's also the medicines data set, which is a little different to the services data set. It includes data from Victoria and South Australia, coded to World Health Organization standards. And there's also the wage replacement data set, which includes every period of wage replacement that these workers received. So our approach, there's a fair bit to it, but we'll discuss kind of the critical bit today. There will be a paper for this coming out in the near future. But today we'll talk about the harmonizing of some of the coding, particularly the services coding. So what do we mean with data harmonization? For claims, that's pretty straightforward. Most instances of data are either inherently logical or based on national standards, but we may have to do some cleaning. So one jurisdiction might record sex as characters like M, F, and U. Others might record them as 0, 1, and 9, and we just have to arrive at a unified standard for those. Same thing with things like dates. The date order could be different. And also other things like employer size. Some jurisdictions might record a continuous variable, like the number of employees. Others may describe an employer as small, medium, and large. So we just have to work with that data to come to an agreed middle ground. Occupation, industry, and others like that, for example, usually meet standards like ASCO and ANSCO, which is the Bureau of Statistics standards for occupational coding. Medicines, the medicines data set was a task in matching medicine descriptions like paracetamol 500 milligram 28 pack to the relevant anatomical therapeutic chemical codes, which is the WHO standard. We also identified or flagged weak and strong opioids as one of the priorities of our research. Wage replacement data is relatively straightforward. It's a payment start date, payment end date, and payment amount. So that was that data set. But we did aggregate some of this data into a cumulative wage replacement duration, which is a common outcome we use in some of our research. The services data set was where it got a little more tricky. So in this instance, what we did was we produced a list of all the unique service items and codes and descriptions from each data custodian that provided us with data. Where possible, we attempted to match these to the MBS, which we could do with with a joining function. If that wasn't possible, regardless, we screened those services for their eligibility for each, I suppose, tranche of services that we were looking at. So, for example, we started with general practitioner services. So we were looking for things that would describe a general practitioner service. So 2 investigators screened those for eligibility, and a 3rd investigator arbitrated any disagreements. And then we worked together to create a harmonized coding scheme to describe some of these services. So some services were very detailed. For example, a GP service could be a 15-minute consultation in clinics, quite a detailed service. Some were less detailed. So we arrived in the middle ground, which was describing where the GP had an interaction with the patient, or where the GP had just been doing paperwork, which is something not usually included in the MBS, is kind of the administration of workers' compensation. Once we'd arrived on those definitions and put all the data sets back together, we had a harmonized data set. And we repeated this for each tranche of services. So we did it for physical therapy services, psychological therapy services, and so on. So what does a database look like? Most claims are for low back pain, about half of them. And most claims are also for time loss, so 63%. Variables include the kind of standard variables we often see in claims data, like age, sex, and occupation, but we've also joined Bureau of Statistics standards like the Index of Relative Socioeconomic Advantage and Disadvantage, as well as the Accessibility and Remoteness Index to the residential postcode of claims in the data. In terms of the services data set, that's gotten quite large at this point. You can see here just a brief figure of the total number of services in that data set. Based on the conditions of limb fracture, low back pain, and muscle and tendon issues, so musculoskeletal conditions, physical therapists is the dominant service in our data set, but also doctors, so GPs. But you can see a breakdown there where physiotherapy is really the major physical therapist service, as an example. Diagnostic procedures really only includes imaging at the moment, but there are some other service categories in there as well. And we can have some pretty interesting insights straight off the bat with this kind of data. So we can immediately ask, well, how many people received each service? In this sample, 85% of people saw a doctor, which was most usually a GP. In the workers' compensation system, GPs are kind of the main point of call who manage claims and manage the workers' recovery. We also see a very high prevalence of physical therapists, again, based on the sample conditions we included. Also quite a high prevalence of diagnostic imaging, which is both prevalent for limb fractures, but also for low back pain in many cases. Quite a high prevalence, well, a reasonable prevalence, I suppose, of examinations and assessments, but you can see psychological therapists, the prevalence is quite low. We can also do some insights that are a bit more interesting in terms of timing of services. So what you're seeing here is effectively a computed histogram. Basically, it's just when most of these services were occurring relative to the date of claim acceptance. So here we can see we've got 0 days up to 2 years, and also this extends 30 days before the claim acceptance date. And we can see some interesting trends immediately with a figure like this. We can see diagnostic procedures in the yellow there, so that's imaging, are occurring, most of them are occurring very early in a claim. So that's the same with doctors and physical therapists. But we can also see psychological therapists, really the number of services is distributed across the entire 2 years of the claim. So distributed quite along the claim process. And the same thing with things like examinations and assessments, which appear to occur relatively early in a claim, but we can also see a minor peak there towards the 2-year mark of a claim. So we can immediately see some trends that we might expect, some interesting trends in service utilisation. We've also published a number of papers with this data already. So I won't attempt to describe all of those, but they are available most of them are available online at this point, but we've been able to identify that about half of claims for low back pain receive diagnostic imaging. We've been able to use trajectory modelling to identify distinct patterns of opioid use by workers with low back pain. We've also been able to measure the continuity of care and how that's associated with working time loss. So that's how many times do you see the same GP. We've compared the prevalence and rates of GP services between states in our data set. We've also identified that, as you saw before, over 40% of low back pain claims receive a medical assessment and usually receive about 2 medical assessments during their claim. And most recently, we've also highlighted that about 9.7, just under 10% of low back pain claims also receive a mental health service at some point during their claim. So where to next? Well, more services, more data, more time. We're in the final stages of analysing some physiotherapy, chiropractor and osteopath services and comparing those. In the future, it would be great to get more data from more of the jurisdictions around the country and also get some more recent data as well. But there's a fair bit of work involved with bringing this data together, so we'll see how we go. We might move on to some questions and discussion. That's okay.
Thank you, Michael. Well, you've whipped through that in no short order. Thank you. That was a lot of work in a short period of time. Michael, we might ask you to unshare your screen.
Yeah, sure.
And we'll open it up for Q&A. We can come back to share the screen if people have specific questions about any of the data that's been presented or information. So if people know how to use Zoom, if you'd like to ask a question, if you could click on the raise your hand button down the bottom, it's under reactions, hit raise hand, and you'll go to the top left of the screen and I can then ask you to ask your question. I've got someone who's done that already, Dylan Slater. Thanks, Dylan. Perhaps if you could just sort of introduce yourself, tell us where you're from and who you are before you ask a question. Thanks a lot.
Thanks, Alex. My name is Dylan. I work for the Humanity Health Group, and I'm currently also studying a part-time PhD, and my focus on work-focused cognitive behavior therapy. So in that data set, you said, I think it said it was around 9%, you said, of people that had a low back pain access psychological therapy. And then in the guidelines for care for mental health for work-related injury, it says if the mental health is secondary to a musculoskeletal issue, then the GP should consider referring for work-focused CBT. Of that data, do you know how many were referred specifically for work-focused psychological therapy, or is it just psychological services as a whole?
You want me to take that one, Alex? Yeah. So the paper that those numbers are from should be published relatively shortly. Actually, the lead author Shannon Gray is actually on the call today. So the data, the way it's structured to kind of meet in the middle with harmonizing between very detailed services and less detailed services, effectively what it would look like is we know there was a patient interaction between between the patient, the worker, and a type of service, so psychology, psychiatry, for example, or counselling and therapists. But we, in the harmonised data set at least, don't know precisely what they would have done in that service. So that's one of the limitations of the data. We know when a service happened and what service happened, but with administrative data, we often are not able to tell what they were doing in that service. The same thing would apply for physical therapy. We know somebody saw a physiotherapist, but we don't know what they actually did in that appointment. So we wouldn't be able to use that data.
And that's the short answer is no, Dylan, I think. And that's the case, particularly for a lot of the allied health services. For in some jurisdictions, in some states where we've got more detailed established coding systems, we get a little bit more insight into what happened. So GPs in particular, I'm thinking about, the MBS codes are a bit more detailed, but they still don't really speak to the content of that consultation or that encounter between the worker and the healthcare provider and what really happened. For that, we'd need other sorts of information, I think. It'd be lovely to imagine a data coding system in our workers' comp schemes that was so sophisticated that it would give us that information. but we're sort of a long way from that at the moment. Does that answer your question, Dylan?
Yes, thank you.
Okay, fantastic. Great question. Up start, I think Dorothy Frost, you've got the floor. Over to you.
Hi guys. Oh, congratulations. That looks so amazing. I just, there's just so much potential to start unpacking that and asking questions. But I just wondered, I think, and I may not have got the numbers correct, but I think you were showing a data set with claimants or people who'd had over 5 days off work. I just wondered, or was it was people with no time off as well? I can't remember. Was it just the over 5 days or was it everything? I think those populations are quite different. I think they should be separated. I think you've got them all together.
It depends on which analysis we've been doing, but those service numbers were for time loss claims only.
Oh, okay, yeah.
In the
that makes sense.
Yeah, in the papers that the analyses that we've done, it's usually similar, but we typically look at claims longer than 2 weeks, which is to account for the wage replacement excess period in some jurisdictions.
Yeah, differences, yeah.
Yeah, exactly. So we try to bring them together as much as possible. We've actually highlighted those differences in services as well in a paper that Alex led on GP services, which is the one I mentioned, comparing states. And we actually ran through a number of scenarios looking at what happens when you restrict the end point of a claim or the start of a claim or the number of services, so we can make more apples and apples comparisons, I suppose, because the jurisdictions are quite different with their policies. There's the wage replacement excess period. There's also the medical excess amount in some jurisdictions. But we have looked at that in a bit of detail. Yeah, but you are very much right.
Okay.
We do have medical only claims in the data, Dorothy, but in the papers we've chosen to focus on time loss claims.
Yeah, great. Thank you.
Okay, great. People are asking questions. So Olwen, I think you were next. Over to you.
Thank you. Hello, everyone. I'm Olwen Anderson. I'm a PhD candidate with Griffith University, and I'm looking at how the support needs of injured workers are assessed. I'm very curious, Michael, looking at your data, whether any findings have emerged about the influence of continuity of care on return to work rates.
Yes, absolutely. So in a paper led by Luke Sheena, who I think is also on the call today, and with Alex and myself, Luke looked at the continuity of GP care and its relationship with time to return to work. I may not do it complete justice in summarising it, but effectively, if you had higher continuity of care, your claim tended to be shorter. That was the gist of that paper. But that's available in, can't remember which journal, but we can send you a copy as well if you'd like.
Thanks, Michael. I'll look it up. Google Scholar is my friend, so I will look it up.
Indeed.
Thank you.
I think I thought that was a Dorothy Dixer question. Oh, and here's one we'd prepared earlier, because we happen to have looked at that. And it's actually Luke may be able to speak to this because he did all the analysis for it, but it's a complex question to answer because a lot of the metrics for continuity of care rely on having a certain number of GP visits in this instance in a set of encounters between a worker and a GP. And of course, the longer someone's on a claim for, the more times they see a GP. So you get this confounding effect between how long someone is on a claim and how long they've seen a GP. So we had to do this sort of relatively complex analysis where we tried to account for the duration of people's claim in order to answer that question about continuity of care. But the key message was actually, as Michael described, is going to see the same GP results on average in shorter durations of time off work. And if you switch your GP more often, you're more likely to be off work for longer. And we think there's a variety of sort of sensible reasons why that happens, which we could go into, but that's taking it away from the data and into the explanation. It's a fascinating topic.
Yes, thank you. I'll look up that paper.
Mark, I think you have your hand up. Mark Potter, over to you.
Yes, thanks. I work for Gen Re, which is a reinsurer in the life insurance industry. I have a particular focus on disability claims. So I was really keen to see what was cooking here. But I was really curious about the durations and whether there was any real observed disparity between isolated areas or lower socioeconomic areas versus the higher ones, regardless of services available or used, whether there was much difference in the actual durations of the claims. Yeah.
We have looked at duration of claim. Do you mean in terms of remoteness, Mark? In terms of like how far out someone is? Something?
Yeah. So if somebody's in a remote area with less access to services, whether that actually made much difference to the actual duration of the claim, whether it was much the same.
Yeah, we've looked at this before using the national data set for compensation-based statistics from Safe Work Australia. So that data set, as I mentioned at the start, it kind of includes all claims. So it's a much larger sample. And in that we have residential postcode, which we can attach remoteness to. I can't remember off the top of my head what the relationship between remoteness and total time loss is. Remoteness and services, absolutely. For example, in the diagnostic imaging paper that I referenced there, we found that remoteness is associated with less access to diagnostic imaging, and it's a similar story for other services that we've seen. The paper I'm thinking of is I'm thinking of the BMJ paper from 2016, Alex. I can't remember the result off the top of my head, but perhaps you might.
Broadly, because we do include remoteness in a lot of the analysis that we do, and there is, if we're looking at sort of time off work as the outcome, there's usually a pretty modest effect. It's there, but it's not as strong as some of the other things that we see. And it's usually that actually depends on whether we're also accounting and adjusting for things like industry and occupation, because in some very remote areas, we actually tend to see shorter durations of time loss. But in the sort of remote and outer suburban or outer urban, I think they're called, areas, it's a little bit longer than the inner urban and city. I would have to go and check, but that's my memory of it. It has a much bigger impact on service access for the reasons I think Michael just described than it does on time loss.
Okay, thank you.
It also, I should note, kind of depends on what we're adjusting for, because we adjust for remoteness, but we're also adjusting for socioeconomic status as well, which can sometimes come out as quite an important variable.
I thought it might also be a bit tricky if you've got different industries in remote areas versus it's sort of not apples with apples, I guess. So
absolutely, yeah. There are some cases in some data as well. You mentioned industry, so mining industries, for example, people might be FIFO, so their residential postcode could be somewhere completely different to where they're working. There's a number of factors to consider.
Thank you.
Okay, wonderful. That's a great set of questions. We've got about 10 minutes to go. So I thought I might just ask one question myself, Michael, and then there's a couple of other things before we wrap up. But I just wondered if you'd seen any similar work internationally on this. And so is this something that is unique to our sort of context in Australia, where we've got this workers' comp schemes in every state and different data systems and those sorts of things, or because I know in some sort of Northern European countries, they're in the fortunate position of not having states and territories. Everything's just national, and they have national health identifiers, so all the databases can be linked, and they run these amazing big registry studies that are very important and influential. But in other countries like Australia, have you come across anything else like this, I guess?
Yeah, I mean, there's a couple of examples. I mean, Canada's quite similar to us in terms of having provinces versus states, but it's a similar thing. They have workers' compensation systems in each province, and so the data end up being quite a bit disaggregated. There have been some efforts by academics over there to combine data from multiple jurisdictions in Canada and produce some quite interesting analyses based on that. America is similar in that there are workers' compensation systems in each state. Studies that we've seen come out of America have typically used data from a single insurer that might operate across multiple states, enabling that kind of comparison between jurisdictions where the policies for those states are still different, but the insurer operates across multiple jurisdictions. So we've seen a number of studies from Liberty Mutual come out over the years to do with looking at opioids for low back pain and diagnostic imaging for low back pain, and that's kind of our point of comparison for some of the studies we've published. But I think, yeah, people in Canada and the US are probably making some similar efforts to what we are with a similar problem of having that data disaggregated between jurisdictions.
Yeah, thank you. Now, in the interest of sort of sticking to time, we might move on. There's one or two things I think we wanted to do before we wrapped up.
Yeah.
The first one, I'm not sure if you've got another slide you wanted to share, Michael.
Yeah.
The first one, perhaps I might just ask people to use the sort of reaction button to give us sort of indication of whether you think you'd like to sort of participate in these going forward, whether you think this has been useful or informative, and also perhaps if anyone wants to volunteer to present something next time, you could get in contact with us. I'll put we'll circulate our contact details. I'm not sure if we have done that already, Michael, in the invitations that went out, but we'll just make sure people can write back to us.
Yeah, absolutely.
All right, and you're showing us I think the results of the poll.
Yeah.
I don't think, looks like we did a not great job of capturing all the different types of organisations, because there's about a quarter of people who are from other who don't fit within one of the categories we came up with, but
yeah,
otherwise fairly well spread, I guess.
Yeah.
Yeah. It would be nice to have got more regulators here to listen to this, but maybe we'll have some success in the future. Okay. So an action for us is just to sort of circulate the contact details and maybe ask people if they would like to present and what they thought. So some sort of feedback form. I wish I had thought about the feedback form before coming into this. And there's one other thing we'd like to ask you about. If you could go back, I think, Michael.
Yeah. This one.
Yep. So we're running a study which is attempting to figure out how our workers' compensation jurisdictions capture, code and report on medicine and healthcare data. And we've sort of been running this since late last year. What we're doing is asking people to complete a brief survey through just a web-based survey form, and particularly people who are involved in or have strong knowledge of data management policies and practices within insurers or within regulators within our workers' comp systems and who are 18 years or older. When we send the slides out, you'll be able to click on that link to the survey, I think. And so far we've had a pretty good response. We've had 20 or 30 people complete the survey, and it's starting to give us a really good picture of what's happening in terms of capturing and reporting and coding of this data, which, as Michael mentioned, is sort of responsible for about $2.5 billion of expenditure in our workers' comp scheme. So we think it's important that we understand how it's captured and reported. But we'd really love it if you could circulate information about this study, or if you are one of those experts yourself, if you could complete the study, that'd be fantastic. Doesn't take long 15 or 20 minutes if you really focus your energies and get through it. So we'd love people to participate in it if we can. I think that's it from us. And we're almost at 15:15, which I think was the time we were supposed to be wrapping up. So I might just sort of open up the floor and see if anyone has any comments or thoughts or further questions to finish the day on. Feel free to unmute yourself and say anything you'd like or not.
Alex, it's Sue Freeman here. Have I unmuted myself okay?
You have.
I have. Oh, good. Look, that was just so interesting. And I guess the burning question for me, sitting here in Sydney and having spent far too much of my life working for the New South Wales regulator, is why your data set doesn't include New South Wales data, and which is really a shame, and whether there's a chance that it will in future.
Yeah, the short answer is there's a good chance it will in future, subject to us, of course, getting the resources and funding we need to continue this work. But we approached almost all of the regulators and insurers, regulators around the country, and we got positive response from pretty much all of them, but it came down to practical considerations. So we were doing this under the sort of a 3-year funded grant from the Australian Research Council, and operational things got in the way, and it got to the point where we just sort of had to move on and begin the study. So that meant that
it's not a reluctance by the regulator, it's more just logistics and operational. Yeah.
Unfortunately, yeah. And I mean, the regulator's been very enthusiastic actually, and we've presented some of this work to them on multiple occasions, and they're very interested in it. So it's not for lack of interest, it's just, yeah, operational reasons and having to deliver the grant that we promised to the Australian Research Council on time, really. So
right, yeah,
there is lots of opportunity there, and we hope to not just include New South Wales in future, but also other jurisdictions if we can. Good question, though. It is the biggest state in the country, so we'd love to have them on board.
Well, and I'm seeing that, you know, you've got the ability, which would be of interest to some of us, to compare. And you mentioned comparing things like patterns of GP service across different states. There'd be lots of interesting comparisons. And so, yeah, it would be a shame if New South Wales isn't in the mix. Yeah.
Yeah. Look, I would say generally when I started doing this sort of work 15 years ago, there was a bit of reluctance from some states and territories to get involved because one of our explicit intentions was to compare. But that's faded away quite a lot. I think we understand the schemes much better now, and so we're able to explain and understand why we see differences in these sorts of outcomes when we observe them.
Yep.
And so we've had terrific buy-in.
Just a note on the New South Wales stuff. One of the things that makes New South Wales much harder to compare with every other state is that New South Wales uses the AMA codes versus the MBS codes for their medical payments, while the other states all use their Medicare codes, which are the coding and the mapping is free and easily accessible. The AMA has put, especially on self-insurers, they've put like a $3,000 a year license cost to be able to map those to the other states. So it makes it really difficult to actually do New South Wales. You either have to create your own tables and map them, or you have to pay a very expensive fee every year to have access to those mapping tables. While the other states who use the Medicare codes, it's easy and freely available to get those mapping.
Mm-hmm.
Yeah, the challenge. Perhaps it's saved us some time in not having New South Wales involved in this study, because it was already a massive challenge in harmonising the coding between the jurisdictions. All right, I'm just conscious of time. I think we might wrap it up there, let people get on with their day. Thank you all for coming along and giving us some of your lunch breaks. And we hope to see you again in a couple of months' time. We'll be in touch with the link for the video, with a rough date for the next one. And we hope some of you in the meantime will get in contact and volunteer to come and present. Otherwise, it'll just be us talking to you all the time about the work we're doing, and that's really not the intention of this. So we're trying to get people to share knowledge and expertise. Thank you all, and enjoy your day.